Hello, everyone, and welcome to our module on cervical cancer. Let's briefly review the cervix. The cervix is the lower portion of the uterus in the female. It's a long cylindrical canal. It has an internal opening towards the uterus, which is often called the internal os, and then it's got an external opening to the vagina, which is often called the external os. And you can see the lower portion here when you do a pelvic exam on a female. You'll be able to see the external os. The main disorder of the cervix you need to know for the Step 1 exam is cervical cancer. It's the third most common gynecologic cancer in the United States. Human papillomavirus is virtually always a component. Most women who have this cancer have infection with HPV, and you can identify the precursor stage with a pap smear, and that's why pap smears are routinely done on women to screen for cervical cancer. Cervical neoplasia develops in the epithelial layer of the cervix, and it occurs in an area called the squamocolumnar junction. As the name implies, this is the junction where the epithelium converts from squamous epithelium to columnar epithelium. So it turns out that the canal of the cervix has columnar epithelium. This is called the endocervix. The outer portion of the cervix has squamous epithelium. This is called the ectocervix. And if you look at this picture on the screen, this is how the cervix looks when you examine it during a speculum exam as part of the pelvic exam on a woman. The red portion here in the middle is the endocervix. It goes down into the canal. Pink portion on the outside here is the ectocervix. So that red portion is columnar epithelium, and the pink portion is squamous epithelium. And this whole area surrounding the squamocolumnar junction is called the transformation zone. That's where the epithelium transforms from columnar to squamous, and 95% of cervical cancers arise here and then extend outward from the inside of the cervix. And this is my own little drawing here of the way I picture this in my head. So you've got columnar epithelium lining the canal of the cervix, and then you've got squamous epithelium lining the outside of the cervix towards the vagina. And here's a picture from the web showing you histologically what the squamocolumnar junction looks like. So this is columnar epithelium over here and squamous epithelium over here, and you can see how it transitions at this point right here. That's called the squamocolumnar junction. The area surrounding this point is called the transformation zone, and this is where these cervical cancers arise from. So what are the risk factors for cervical cancer? The major risk factor is human papillomavirus infection, and we'll talk more about this virus in a minute. A second risk factor is immunodeficiency state, and this is actually related to HPV infection because women who are immunodeficient cannot clear an HPV infection. Cigarette smoking is also a major risk factor for cervical cancer. It affects the secretions in the endocervical glands and makes cervical cancer more likely. Women who've had sexual intercourse at a young age or who have multiple sexual partners are at increased risk, and that's because HPV is sexually transmitted. So these last two risk factors set a woman up for increased risk of exposure to HPV. So let's talk about human papillomavirus. HPV is a non-enveloped, double-stranded circular DNA virus. There are multiple subtypes, for example, 1, 6, 11, 16, and 18. It is the most common sexually transmitted infection, and the disease caused by the virus depends on the subtype. So certain subtypes cause cutaneous warts, others cause genital warts, and others are associated with cervical cancer. Individuals who develop a persistent infection for many years can potentially develop cancer, and there are a number of malignancies associated with HPV infection. Cervical is the main one people think about, but HPV infection is also associated with anal and penile cancer, and also with certain types of oropharyngeal squamous cell cancers like those that occur in the mouth or throat. And subtypes 16 and 18 are the two types most commonly associated with cancer. These are considered the high-risk subtypes for cancer. As I said before, HPV is a sexually transmitted infection, so as you can imagine, there is a high prevalence of HPV exposure among sexually active women. Now, most women will clear the infection, but some will have the infection persist, and among those who have the infection persist, some of them will go on to develop neoplasia of the cervix. There is a vaccine available. It's made from capsid proteins of the virus. Some target the cancer-causing types of virus like 16 and 18, and other vaccines target the genital warts-causing versions of HPV like 11 and 6. So let's talk about some HPV virology. What they want you to know for the Step 1 exam is why certain subtypes of HPV are associated with cancer. And to understand this, you need to know that there are two key oncogenes called E6 and E7 that are found within HPV that are believed to lead to cancer. The E6 gene codes for a protein that inhibits the P53 tumor suppressor gene. P53 is a protein that I talk about in the cell biology section in the video on the cell cycle. It controls the cell cycle progression from G1 to S phase. So when this E6 gene becomes active inside of HPV, it inhibits P53, and that leads to lack of control over cell growth, and that leads to malignancy. The E7 gene codes for a protein that inhibits the retinoblastoma tumor suppressor gene, and I also talk about this protein in the cell cycle video in the cell biology section. RB protein inactivates the E2F transcription factor, so when you inhibit RB, you then get E2F activation, which leads to uncontrolled growth. Here's one of the slides from the cell cycle video in the cell biology section. So P53's role is to become stabilized and active when there's DNA damage. It will then go and activate the P21 gene, and the P21 gene product will lead to growth arrest. So when HPV inactivates P53, then this whole process can't occur, and that means that you do not get growth arrest in the setting of DNA damage. Instead, you get continued growth, and that's what leads to malignancy. And here's another slide from our cell cycle video showing you what retinoblastoma protein does. So normally when it's active, it inactivates E2F, but when HPV infection comes along and knocks out the RB protein, then E2F is free to go along and drive cell growth, and this leads to uncontrolled cell growth, which can lead to cervical cancer. Cervical neoplasia progresses slowly through a number of stages until it becomes carcinoma, and pathologists have a couple of ways that they classify the stages as cervical neoplasia progresses. One system pathologists use is to classify lesions as cervical intraepithelial neoplasia, or CIN. By this system, biopsies can be classified as CIN1, which is a low-grade lesion, whereas CIN2 and 3 are higher-grade lesions that are closer to carcinoma. The other system pathologists use is to classify lesions as squamous intraepithelial lesions, or SIL. By this system, lesions can be low-grade squamous intraepithelial lesions, or LSILs, or they can be high-grade squamous intraepithelial lesions, or HSILs. And obviously, the higher-grade lesions are getting closer to carcinoma. If we go back to this picture here, this is what normal cervical squamous epithelium should look like. In a CIN1 lesion, as is shown on the screen here, we now have some dark purple cells beginning to move their way up from the basal layer towards the surface of the epithelium. And then in a CIN3 lesion, we have dark purple nuclei of cancer cells occupying the entire epithelial layer. It's unlikely on your boards they'll ask you to call lesions CIN1, 2, or 3. That's something that's usually on pathology board exams. You should just be familiar with the general idea here. If CIN lesions go undetected and untreated, they can progress to develop into cervical carcinoma. And most commonly, cervical carcinoma is squamous cell carcinoma. Second most commonly, it can be an adenocarcinoma if the cancer is of endocervix origin. Remember that the endocervix has that columnar epithelium. Almost always, cervical cancer occurs in women with HPV infection. You can actually see high-grade lesions and cervical cancer when you do a pelvic exam. This is a picture of what the cervix can look like in that situation. This is usually in a woman in her 40s or 50s, and it's almost always in a woman who did not get screened. If women have been having regular pap smears, they should never progress to develop cervical carcinoma. Usually, cervical carcinoma is asymptomatic, but it may present as vaginal bleeding. A woman may report irregular or heavy menses, or a classic presentation is for a woman to complain of postcoital bleeding. And it can invade locally and involve the bladder and the rectum, which, as you know, are close to the cervix. Diagnosis of cervical carcinoma involves colposcopy, which you will see on your GYN rotations. This involves using a device called a colposcope, which allows a bright magnified view of the cervix so you can closely inspect the epithelial layer. Biopsy is often done, which is how CIN lesions are identified and carcinoma is identified. And all of these things, colposcopy and biopsy, are usually done to follow up after a woman has had an abnormal pap smear, which is the screening test of choice for cervical carcinoma. So now let's talk about the pap smear. The pap smear is a form of secondary prevention for cervical neoplasia. It is a screening test that looks for cervical dysplasia and carcinoma. It does not prevent dysplasia and carcinoma, but it identifies it at an early stage when it is treatable. That's why it's called a form of secondary prevention. And the idea here is to take a sample of the cervical epithelium and look for the presence of koilocytes. Koilocytes are epithelial cells infected by HPV. They have large dark nuclei. This is a picture of a koilocyte shown on the screen here. And this test is best at detecting squamous cell carcinoma, the more common type of carcinoma of the cervix. It's less effective at screening for adenocarcinoma. And that concludes our video on cervical cancer.